Hello, everyone. My name is Matthew Webb, and I'm a student physical therapist with a CSCS and a BS in nutrition science. Today, I'm going to be talking about potassium, and this here is going to be the 14th in a series of educational videos intended for healthcare professionals to help us in direct access healthcare fields become more adept at identifying nutritional deficiencies so that we can get patients presenting with one of these diseases the help that they need. So, without any further ado, allow me to present to you potassium. First, we're going to go into the very basics behind deficiency of potassium. Then we're going to break down the science behind why patients are presenting the way that they do. Then I'll give you some takeaways to help you identify this disease. When a patient has potassium deficiency, they can develop heart arrhythmias, numbness and tingling, muscle weakness, and hyperreflexia. And we'll go further into the science behind these presentations and the risk factor later in this presentation. But I just wanted to provide you an idea of what we're going to be getting into in this lecture right here. Here is the impacts of potassium deficiency on the heart. This is specifically relating to cardiomyocyte action potentials. Nodal tissue action potentials look different than this. However, they're impacted in a very similar way. So I'll just describe the cardiomyocyte perspective. So, after an action potential, potassium being pumped out of the cell is a necessary part of repolarization to reset the cell for the next action potential. Then, when we're deficient in potassium, there's an increase in intracellular sodium and calcium, and of course, a decrease in intracellular potassium. This electrolyte imbalance inhibits the repolarizing outflow of potassium, which you can see that what it is normally supposed to look like in the second action potential picture, with all of the potassium indicated by the letter K next to those arrows indicating that it is exiting the cell. When this is dysfunctional, it causes a prolonged action potential. A prolonged action potential is associated with something called an early after depolarization, which is a secondary depolarization that occurs in phase 2 and 3 of the action potential. And delayed after depolarizations, which is a secondary depolarization that can occur in the fourth phase of an action potential. Both of these things can trigger arrhythmias such as ventricular tachycardia, torsade de pointes, PVCs, and AFib. Now, what's fascinating here, which we'll see in the next slide, is that cardiomyocytes become more excitable, whereas neurons become less excitable, which is somewhat of an interesting paradox. So, potassium deficiency causes hyperpolarization of the neuron. That means it becomes more negative. And if you look at the second picture on the slide, you can check out how big the difference between the resting potential and the threshold potential can become compared to the difference in a normal neuron. The reason it's so wide is because the decreased extracellular potassium drives more potassium out of the cell due to the greater concentration gradient. That decreased potassium increases the cell negativity. Due to the increased distance from the resting potential to the threshold potential, a much stronger stimulus will be required to trigger an action potential. This inhibits nerve conduction and can lead to sensory loss, decreased muscle responsiveness, and hyperreflexia. Here's some factors you can look out for. Alcoholism impairs magnesium absorption due to intestinal damage. Kidney disease, including some unique kidney diseases such as Bartter syndrome and Gittleman syndrome, can increase potassium excretion, which increases risk. Hyperthyroidism can increase potassium excretion by the kidneys. Cushing's syndrome increases cortisol, which promotes potassium excretion in kidneys. For the same reason as Cushing's syndrome, corticosteroids can do the same thing. As far as drugs go, insulin increases potassium excretion and can cause potassium to enter cells, which can both lead to low blood potassium or hypokalemia. Thiazide and loop diuretics increase potassium excretion. Beta 2 agonists, such as an asthma inhaler, can increase potassium entering the cells, which causes a decrease in blood potassium. Subjective questions to ask would be about past medical history, and you should make note of kidney disease, hypothyroidism, and Cushing's syndrome. Sorry, hyperthyroidism. Ask them what medications they're taking. Make note of corticosteroids, insulin, thiazide, and loop diuretics, as well as beta 2 agonists. Ask about any alcohol consumption, and of course, find out what that looks like. Diseases that individuals can be at greater risk for with potassium deficiency are arrhythmias, heart disease, respiratory failure, and kidney dysfunction. For clinical exam, neurofindings will include numbness and tingling in distal extremities, hyperreflexia, and muscle weakness. Cardiovascular findings can include tachycardia as well as many other fast heartbeat arrhythmias. The main takeaways as far as the what, how, and why behind the presentation is that potassium deficiency can lead to tachycardia. This is because potassium is supposed to be pumped out of the cardiomyocyte to reset the cell for the next action potential. When potassium is low in cardiomyocytes, intracellular sodium and calcium increase. This impairs the ability of the cell to depolarize following an action potential, which can prolong the action potential. A prolonged action potential is associated with early after depolarizations, which is a secondary depolarization that occurs in phases 2 and 3 of the action potential, and delayed after depolarizations, a secondary depolarization that can occur in phase 4 of an action potential. Both of these can trigger arrhythmias such as ventricular tachycardia, torsade de pointes, PVCs, and AFib. Potassium deficiency can also lead to neurosigns like hyporeflexia and muscle weakness. With low potassium levels in neurons, the neurons become overly negative or hyperpolarized. This means a much stronger stimulus will be required to trigger an action potential. Thus, nerve conduction is inhibited, which is the reason for muscle weakness and hyporeflexia. And here are my resources. Thanks for watching. Note that I'm making these presentations during a pretty busy semester, so I'm liable to make some mistakes. So let me know in the comments, and if your corrections check out, then I'll either add it to the video description or I'll pin your comment. If you learned something from this video and you want to learn more, continue on to the sodium